Okay, we are going to jump into questions. And I think instead of having both of you answer the questions, because we have a lot of questions to answer and I know we won't be able to get to them. So maybe we'll just kind of go back and forth on the different questions, but feel free to weigh in if you have, if you feel the need, because you may have something important to contribute there. Michael's asking a question. Dr. Fonseca, maybe you take this first question. Is there hope for a vaccine for smoldering myeloma or myeloma? And they were referencing a smoldering myeloma trial.
Oh, yes, there's plenty of hope. Work is going on. There's every reason to believe that a right design would lead to that. And why not? Can we aspire to a future where people have an MGUS and then they get a vaccine against progression to smoldering or to active myeloma? So the short answer is yes. Still not a lot of specifics, but I know trials are going on, but the answer is yes.
Okay, perfect. And Dr. Landgren, Joanne is asking, is there any known correlation between hyperparathyroidism and MGUS? Because I know you do a lot of work in smoldering myeloma and MGUS.
I think statistically speaking, there probably is a slightly higher rate of people with MGUS having these types of conditions, hyperparathyroid, because these disorders probably are immunologic disorders. And although we don't really understand how it works, I think there could probably be some autoantibodies that could be released by some cells that could have autoimmune disorders, and they could also reflect in monoclonal proteins. When it comes to the specifics and the details, how it works, which came first, and if it would have any implications, these are unknowns. I would think that these are, if a patient has that, it wouldn't change anything for the purpose of the MGUS. There is no worse prognosis or anything like that.
Okay, great, thank you. And Dr. Fonseca, can Candara FastPro be used as maintenance alone? Because I don't know where Dara stands as a maintenance therapy, or should it always be used with Revlimid?
Yeah, so it probably works. There's clinical trials going on. The most famous or most notable one is the Auriga clinical trial that compares daratumumab with the lenalidomide, the Revlimid versus Revlimid. But I think it's important to recognize a lot of the words we use to describe different phases of treatment is really that, just more treatment. And what we were learning is more of the good treatment is important. So I anticipate that Dara will probably be part of maintenance in the future. And if someone couldn't have maintenance with a Revlimid for whatever reason, intolerance, blood counts, etc., I don't think it would be unreasonable for the person to consider that for Dara. But these are very individual decisions. So I would say discuss with your doctor.
Okay, great. And Christine is asking a question. I'm going to make her question, but a little bit more broad. About personalized medicine. There was a lot of work you heard maybe 5 years ago, a ton on the genetics or like submutations or things like that. And now you're incorporating, imaging and MRD status and how you responded to therapies and things like that. Dr. Langer, do you want to talk about how you get to I guess, personalize therapy? Or what's the best way to do that with current medications that are available?
Yeah, I think the word personalized therapy is probably different in different diseases. So if you think about a patient who presents with lung cancer, let's say, it has been known for many years now that some lung cancer tumors have certain mutations and other lung cancer tumors have other mutations. And they use inhibitors that block these pathways depending on what mutations are identified. So lung cancer is an example where you have these targeted drugs and the biology really guides the therapy. In multiple myeloma, there are very many mutations. So if you do whole genome sequencing, if you capture everything, you would see that the average patient has between 5,000 and 6,000 mutations, if you include everything. So it's not going to be possible to give 6,000 drugs, obviously. Also, these mutations are not the same in every single myeloma cell. So I think myeloma is different, obviously, biologically. I think that the personal concept, in my mind, is more centered on the monitoring of the response. So if you can treat the patient and the response to the therapy is of a certain magnitude, maybe that could then be used to guide and change the therapy. Rafael was saying that skipping maybe transplant or holding off with that, keeping the cells, having it as a backup if patient reaches MRD. To me, that is MRD guided therapy, that is personalized therapy to me. Also, there are, of course, patients who have certain features like 11-14 translocation that has been found to be associated with BCL2 activation. And you can use a BCL2 blocker. So that's an example in the direction of lung cancer, if you want, where biology ties up. That's not yet FDA approved, but could there be additional drugs coming? There probably will, but most of the drugs are more broad and given in combination. So I think personalized medicine is more along the lines of measuring response and not giving every patient the same number of cycles of the same drugs all the time, but to do it more individualized based on response.
Okay, great. Thank you for that answer. And Dr. Fonseca, you both sort of talked about this, but when do you anticipate a liquid biopsy that's sufficient to do multiple types of testing on it?
So
I was asking that question.
yeah, there's a lot in that question. If one thinks about a liquid biopsy as a way to try to find some of the mutations that exist in the bone marrow, probably, it could be done now, although it's not really in any way in a form that is FDA approved or people do it routinely. So it can be done in academic centers. But the reality is that most of us still think there's more information from doing the bone marrow, because the bone marrow gives you more information, gives you a better sample, gives more reliable results, etc. Another way to ask this question would be, can we use a liquid biopsy from the blood to monitor the disease? And the answer is probably yes. But from what we know, because of the behavior of myeloma that likes to live inside the bone marrow space, it probably does not have the sensitivity as what we do when we get the bone marrow. So when people have looked at it, there's usually about a 10-fold difference in your ability to detect things if you're using that just to measure the MRD. There's some new developments, for instance, with the measuring of very low concentration of some of the peptides, or that is the small proteins, through something that people may have heard, which is the mass fix or the MALDI-TOF. But I think there's quite likely to be a need for a bone marrow for some time. So I would say, yes, people are working on the technology, but I think more and more the center should work on offering the bone marrows with sedation to patients, because that makes a big difference on your ability to convince someone to have the procedure.
Yes, I vote for that. And I always get that. And yeah, because you can kind of develop PTSD if you get too many of them about doing that. Bonnie's asking a question, Dr. Langer, maybe you want to take this one. How can we make clinical trial enrollment studies easier for patients, like using local clinics for testing or telemedicine? And also, what technologies would allow non-secretory patients to participate? Because that's a big deal for patients who can't qualify.
Yeah, so when it comes to the first question here on clinical trials, I think there are certain things that are kind of beyond our control, and that kind of refers to the regulation, and all these things are for patient safety. So I think they have to be in place. Everything has to always be done right and safe. That is like not negotiable. So unfortunately, that also means that there are like extra tests and there are kind of some delay because everything has to be double checked, but that is really in the best interest of the individual patient. So that cannot be changed. I do think within a given organization, if a trial is open, many of the big centers have satellites. Here we have 5 or 10 different satellites around Miami. I cannot go to every satellite and see patients. The research staff cannot go out and be present every day all the time. So the way we solve it here is basically telemedicine. So a patient can be in Broward County, and the staff can be in Miami, 14th Street in downtown Miami. And the patient can see the staff on the monitor in the clinic that belongs to the institution. I'm sure Mayo and all the other centers probably have similar models. So that really brings the trials where the patient lives. So instead of driving an hour into the city, you can go to the closer satellite that is integrated in the system. I've seen this happening. I saw it happening in Sloan Kettering when I worked there. We rolled it out in New Jersey and in Long Island and Westchester and so forth. We had the research staff located in Manhattan, but patients didn't want to drive into the city because of all the traffic and all those things. So I think that's a big improvement for patients. And the drugs can be given by nurses. So I think the whole telemedicine has really taught us so many things. We can use it long distance, but we can also do it in the micro kind of setting like this. When it comes to the non-secretory patients you mentioned, so we know that about 80% of patients have monoclonal proteins. Most of those patients also overproduce light chains. This is the most common type of myeloma biology in the blood, if you want. 20% of patients about have only light chains overproduced in the blood. Then there's a very small proportion of patients that have none of these. They have neither M spikes or light chains overproduced. Probably this is because of mutations impacting the genes that code for the making of these proteins. But from a drug development point of view, the FDA wants to make sure that the drugs can be quantified to have a benefit. And there are rules that have been developed over years. What is a response, a partial response, a complete response, and so forth. So in order to have a patient being evaluated for that, there has to be some form of measurable disease that's quantifiable. And that's kind of where all this comes back. So if you don't have any quantifiable disease, how do you then prove it? You could technically open protocols and have non-secretory disease and have other measures, but then it would be hard to do this assessment and say partial response or complete response. So it would make it harder to do the trials. We come back to what I said before. Mm-hmm. The individual patient would be great to be on it, but if there are too many patients like that on the trial may not be successful, the drug may not be approved, and then no one will get the drug.
Yeah.
So
right.
That's kind of a tricky balance there.
Mm-hmm. Yeah, I know. There are so many considerations, and you want it to get approved as fast as possible. So it's tough for those patients, though, because a lot of them are looking for options.
But I do think there are other biomarkers in development. BCMA can be measured. BCMA may be an alternative in the future, and there could be other markers as well. None of this is yet validated and endorsed, but there could be new biomarkers coming. So we are working on that together. Rafael is involved in this too.
Mm-hmm. Wonderful. Dr. Fonseca, Richard has a question. And you had kind of talked about subtracting transplant at some point, using something else first, because we know we can always use it later. His question is, would you do CAR T-cell procedure instead of stem cell transplant as an early therapy, either early relapse or newly diagnosed? And maybe you can talk about the scenarios in which you'd consider doing that.
Yes. Well, first of all, I would be so lucky to have access to CAR T-cells at this moment, right, for doing something like that. But where in a situation where I had the opportunity to test CAR T-cells versus stem cell transplant in a clinical trial, I would encourage my patients to consider that strongly. I always tell patients I'm not a transplant specialist in the way that my life centers on myeloma, not on the treatment modality, not transplant. There's people I go to transplant meetings and they don't care if they're transplanting lymphoma, myeloma. I don't. I care about myeloma. But I'm still not ready to completely move away from transplant as an option for patients, because it seems like it adds on whatever you have achieved. Now, how much it adds and how much that is worth to someone, everyone is different. But even in the very recent Forte clinical trial, transplant seemed to even get the bar a little bit higher. Now, it depends on, some people might say, well, that's not much of a gain for me, but I think it's still important when you think about the long-term outcome. So I'm not ready to give up on transplant until we know that the alternatives are just as good. But I hope we can give up on transplant, because I know what a big deal it is and how it derails someone's life for weeks or months until you get fully back on your feet. I always tell my patients it's a very safe procedure. It will never be routine for you. It's routine for us in the clinic. But it's a big deal. So you can get away from that. So I know groups like Dr. Langre, Dr. Costa is exploring this too as well. I think the question will be better addressed once we ask the question, okay, if you get, let's say, 6 cycles of treatment and you're MRD negative, maybe you collect cells and you keep going with that treatment, or maybe you don't even collect cells, but keep going with that treatment. And if you continue to show that level of response, then what is the incremental gain of having that transplant for you as an individual? So it's very tough questions, but I hope there's a future without transplant.
Yeah, we don't know that, right? We don't know if CAR T will be, like, if you use it first line therapy, if it'll be, because sometimes the strategy right now is to just get you out as far as you can while the development's happening and you get these questions answered scientifically, and then so sometimes that was my strategy even 10 years ago, was let's do the thing that will get me out the longest while the development's happening.
Yep. And that's what the economists call the value of options, right? So you open options you don't have as of now, but because of the time you gain by doing what you did.
Right, right. Okay, Dr. Landgren, you were talking about MRD negativity. So Jim was asking if you're MRD negative at 10.5 or 10.6, like to 100,000 or a million cells, how often should the MRD status be evaluated? And you both talked about making treatment decisions based on MRD negativity, and he was asking specifically about Dr. Costa's master trial.
Yeah, so when we talk about MRD negativity, we had an agreement several years ago. It was in 2016. There was a publication that we published together in the community, in the myeloma community, from the International Myeloma Working Group. And we said that you should never use the word MRD negativity unless you can rule out presence of one cell in 100,000. So if you cannot rule out one cell in 100,000, don't use the word MRD negativity. In the past, people used MRD negativity if they felt that was what it was. So that kind of standardized the field. And since then, there's been work going, and I think Adaptive Biotech's, the clonoSEQ assay they have developed, technically has 10 times more sensitive capability. So you can rule out one cell in a million. And of course, people have now looked since this earlier work was done to see if that really makes a clinical difference. And if you look at progression-free survival curves from patients that were tested with 10 to minus 6, one cell in a million, and then you use the same data, but you ignore many data points, so it's the equivalent of one cell in 100,000. You can switch a high-definition TV, switch it over to black and white TV sort of thing, to see if there's a difference. So the curves are different and favoring 10 to minus 6. I think there is no doubt that that is a better way to do it. Recently, it has not been updated by the IMWGs because IMWG is an international consortium with people from all over the world. And in the US, we are probably several years ahead of most of the other parts. So if we say 10 to minus 6, no one else can participate. And this is about putting it in clinical trials. So I think what's happening now is that people are capturing 10 to minus 6 and they capture 10 to minus 5, depending on what they have access to. But they report in the studies how it was done. So here in the US, we have Adaptive Biotech. It's FDA cleared. It's CMS approved. So Medicare would pay for it. When it comes to how often to do it, it's really the biopsy and the test that's run we are talking about. And the NCCN guideline says that it's reasonable to repeat it on an annual basis. So this is not the law, but this is kind of, that's the Bible that clinicians are looking at, the insurance companies are looking at it. Sometimes they read the same sentence and the insurance would say, we're not going to pay for it, while the doctor says you have to pay for it, and it can become a battle. And I'm sure you know what I'm talking about.
Yes.
But I think in my experience, once a year is usually considered to be in line with these guidelines.
Okay, great. Thank you. That's very helpful. Dr. Fonseca, Jackie's asking a question that's maybe in, yeah, well, I'll just state the question. At relapse, is there a philosophy to save some therapies for later, and what criteria is used to determine now and later? I've heard that question a lot over a long period of time.
Sure. No, it's a very legitimate question, and I'll tell you where we are in the thinking in that regard. We have asked ourselves the question, if you follow patients, a defined group of patients from when they go to the first treatment, when they go to the second one, and so on, there is a process of attrition, meaning you can't always assume that if you get one line of treatment, that you're going to have an opportunity to get the next line of treatment. And that's for a number of reasons. Sometimes for very good reasons, people do very well with treatment. They don't need more treatment. But sometimes for the reasons we don't want to see, the disease progresses or the patient gets tired, or something happens that makes the patient unable to get further treatment. And we have looked at those numbers, and the numbers are pretty high. It's not like a small percent. There's a significant fraction of patients that don't get to the next line of treatment. Because of that, and it is very hard to prove this in a direct way, but because of that, I think more and more, all of us in the myeloma community hold the belief that you should not keep some dry powder for later. You should not hold treatments for later, but rather use the best you have right now, because then you use that opportunity to do the best there is. And second of all, if you get longer duration of treatment after that, then you're going to open up those opportunities you talked about, Jenny, like with your approach, right? So there is just to give the audience an idea, and if you were to say, well, why don't we use something like, just a simple doublet like Velcade and dexamethasone for a relapse? It turns out that only works for about 7 months. And that's very short. And then at the end of that, the person may be tired and say, doctor, I'm fed up. I don't want to do anything else, or my family's tired, or I just cannot carry on. So I would say use the best there's available possible, knowing that by the time the period of that benefit finishes, there may be something completely new, like a CAR T cell or a bispecific at that time.
And that's why in the very beginning of our program, you talked about using quads up front, and that's kind of that whole reasonable strategy, and how patients without transplant were even getting these astounding outcomes.
Sure.
Okay, Dr. Langren, Georgie's asking, are there any new treatments or trials specifically for deletion 17 patients?
There is no, to my knowledge, drug that has been found to be the drug that should be done. There are trials in development for high-risk disease. There is not 100% consensus in the field on high-risk disease. I don't think there are any 17p only trials, to my knowledge. Correct me if I'm wrong, Raphael, but there are trials in development for high-risk disease. And I think people have not really agreed what is high-risk disease, and people also have different ways of thinking how to treat it. So I think from what I know, the next generation of these high-risk disease protocols will allow the doctors at the local centers participating with their patients to give a certain number of cycles of what they believe is the right thing. And then there could be some additional steps, for example, CAR T cells or something like that. And then the maintenance continued therapies could also be stipulated by the protocol. So the first steps could be individualized, and then using other therapies like CAR T cells and maintenance therapies with multiple drugs. I think ideally, if we could, in my opinion, if the centers around the world agreed to share data on biology, and we could put that together, we talked about machine learning before, artificial intelligence. If we could really carve out what is different in these patients and see also how there are potentially different subsets. I don't think there is one group of high risk. I think there are multiple different groups, and try to better understand both the biology and other clinical properties of the disease. I think that would, in my opinion, be a more rational way. So right now, it's just like giving the best therapies we have earlier. That's sort of what these trials are about. I don't know what Raphael thinks about this.
No, I agree with everything you said, Ola, and just to add just one extra layer, and this is in no way self-serving. I think from the audience, that these matters have become very, very complex. Mm-hmm. We offer, to the extent possible, to co-participate sometimes in the decision-making process and the care, because, what we're saying, it's common sort of knowledge or parlance, if you may, in the myeloma community, but it's really hard to expect that people that are out there in the community who have to see breast cancer and colon cancer and all those other things will be able to be on top. I know everyone's time is so limited, and we wish we could do more, but I think fortunately there's many centers across the nation that participate in the care of myeloma patients.
I would like to add one last thing on this topic, Jennifer. So in my laboratory, I mentioned we do whole genome sequencing and single cell sequencing. We have gathered a few thousand samples, and we also have all the detailed information on clinical outcome and therapy. And we are starting to go through this using artificial intelligence in our laboratory. And we are starting to see things that we never really thought about. So I think that if we could, more groups could start doing this and we could partner with each other, I think that would be a very powerful way forward. I think HealthTree would be a fantastic collaborator in this context as well.
Mm-hmm. Well, we would be happy to do that. I think it'd be wonderful. Okay, Richard is asking a question about, can you tell us about SbCma testing for prognosis and evaluation of treatment? I know we've heard a little bit about BCMA levels, like tracking when you relapse and going down when you're not, or Dr. Langer, do you want to address that topic?
Can you repeat the question again, please?
Can you tell us about SbCma testing for prognosis and evaluation of treatment, like tracking the BCMA level?
Yeah, so SbCma refers to soluble BCMA. So what happens is that BCMA stands for B cell maturation antigen. It's a protein that is expressed on the surface of different types of cells in the body. It's typically expressed on most myeloma cells in patients with myeloma. The cells don't only express this antigen, they also they shed it, meaning that they kind of release it and send it out in the blood. This can be used for tracking, obviously, and you can see if there are high amounts, which would be an indicator that there are a lot of cells that are shedding. But what's really not clearly known from a sophisticated scientific point of view is really how this comes into play for therapy. So you could envision certain scenarios. Say that you have someone who has a lot of myeloma, and the cells make BCMA and shed it. And now you treat it, so there are fewer cells. But maybe the therapy also downregulates BCMA, and maybe it also manipulates the shedding. So because I've now mentioned volume of disease, expression, and shedding, these are three different variables. Ideally, the amount in the blood only reflect one variable at a time, then it's a good biomarker. So if you have more disease or less disease and a high level and low level, that would be a good biomarker. But if the drugs impact the shedding and the expression, that makes the biomarker more difficult to evaluate. And I think that's where there is work that needs to be done. There are other variables as well. So I think right now, my read of the literature is that BCMA overexpression, soluble BCMA in the blood, correlates with higher levels of monoclonal protein. But my read of the literature is that that is not obvious to me that it adds any known clinical benefit beyond proteins. It may in the future change. I don't know if you have other insights, Rafael.
No, I think you hit the high points, and you know, like you said, it could be one of several other markers. The part of the problem too is that we all have, you know, if you don't have myeloma, you have normal BCMA in circulation, and they're working with some of the various reagents that measure that. I thought that we probably that might be an opportunity to measure also circulating tumor DNA and other things as biomarkers, which is being done in other tumor types. And you know, it's a reminder that we are very fortunate in myeloma to have all of these biomarkers. And again, it's just a reflection of the biology. But I always think my colleagues who treat colon cancer and have to make decisions based on a CAT scan that they repeat every 6 months, and they see just what is the size of some nodules that may be there. It's just a different world. So the ability that we have to track with more precision what's going on is so much greater in myeloma, and the non-secretor state is just a reminder of how it is in other tumor types.
Mm-hmm. Yeah, really good point. Dr. Fonseca, Tim is asking, is there any suggestion that immunotherapy is less effective after stem cell transplant?
I'm thinking a little bit. I don't think there's suggestions, and maybe Dr. Langren has examples, but it is possible. It is possible that someone could have that for whatever reason of exposure to the melphalan, for instance. But I haven't seen any direct suggestions. But like we were saying before, hopefully there's a future where you can bypass the melphalan as part of your treatment.
Okay, well, yeah, we look forward to the future in myeloma care. Dr. Langren, someone is asking if MRD is this holy grail, now MRD negativity, should I add drugs or change therapy even if I'm clinically satisfactory? That was kind of an induction question too, like, how far do I keep going until I get this transplant? Do I keep going till I hit that point? Or because some patients can kind of have a really good outcome for a really long time with having just a little bit of disease.
Yes, well, I think if I understand this question correctly, I think the question is, if I'm treated from the beginning and I don't reach MRD negativity with a planned therapy, should I keep on doing more therapy so I reach MRD negativity? That's the question. Yeah. That's a good question. I think the fair answer is that no one really knows. That's probably a safe answer. But I do think there's always more granularity. We could look into big studies, or we could go to centers that see a lot of patients and they know what's going to happen probably 5 years before the papers are published, these large studies. So if I look at our databases and think about what I've seen with my own eyes and talking to all the faculty, I think if patient reads MRD negativity, say from a new diagnosis, say within 6 or 8 months, to me, that's a prognostic marker that tells me that this disease is sensitive to the therapy we're giving. Most patients that reach that in my hands will sustain the MRD negativity over time. Unfortunately, there is a group of patients, a small group of patients, I don't know what number that is, say 5% or something in that range. I'm not sure about the exact details, but something like that could lose their MRD negativity in the following year. Those patients, in my experience, are progressing as the next step. But I think there are patients that did not reach MRD negativity with the measures we use. But if I follow them over time, I see two groups of patients. There is one group that is barely positive, but they are positive enough so I cannot call them negative. And if I check them from year 1 to year 2 to year 3 to year 4, they just sit at that level. To me, in my clinical experience, they are not very different from the one that are sustained MRD negative. And I almost think about it as a reflection of the fact that every technology has its sensitivity limitations. So we can detect certain number of cells, and that means that some are positive, some are negative. But if you have an even more sensitive, both these two examples would be positive. So it's kind of depending on where we draw the line. So I think the dynamics of MRD is critical. And then you have the last group, which is patients that are not negative, they are positive, but they have a lot of disease. That's also a group where you would see progression because you basically did not give a therapy that was a therapy that got rid of the disease. So I think if there is a lot of disease left, or you go negative and you bounce back, that's a small group of patients. So if you put all this in context, to try to go back to the question here, if you know all the patients that are barely positive, what should you do? Should you just keep on going with maintenance and monitor, or should you try to roll it into negative? I don't know, but I share with you that there are these patients that have the dynamics of stable. In reality, a lot of patients are asking if they can get 2 more cycles or something like that. And we would try that. And some patients turn negative, some patients don't. Some patients turn negative a year into maintenance, and some don't. So again, these are different dynamics of disease. I would not double transplant or do an allogeneic transplant or something crazy like that just to make it MRD negative based on what I know. So I would kind of play along the lines of what I outlined here. It's a difficult and very good question.
And Jenny, maybe to complement, because we talk so much about it, and there might be people in the audience that are thinking, oh boy, I'm not MRD negative. I think it's a good goal from when we start treatment. And there is no question that we're trying to do everything to get there. But it's like, you finishing high school and getting an A+, right? That's our goal. If you have a B+, you can still do very well in life, right? So it's not 100% deterministic. If I had my choice, I would want all my patients to have an A+ response. And I'm reminded constantly, and Dr. Langren and I have patients that even before the time we measured MRD, we had patients who completed therapy and have a small amount of residual disease that is kind of quiet, a bit like an mgus. And, some patients that I have patients that are 15 years plus who have an M spike of 0.3 after transplant, even before we did maintenance. So these patients were not on maintenance, were doing very well. So from the get-go at the start line, yes, that's the goal. I would try to do everything to get us there in a safe way. So, to the last point that Dr. Langer was going to make, but some patients cannot get there, and it may not necessarily mean, it's just time to, forget it. No, there are options and there are things we can do, and there can be very good outcomes. When you look at the experience from the Spanish group that they looked at 20-year outcomes, there were some patients who had only achieved a PR who were still well controlled 20 years later.
And that's only partial response. Yeah. So that's, yeah. Interesting. Yeah. So just watch the rate and the rise when you're looking at your labs to work with your doctor. Dr. Fonseca, Frank asked a question too, like, if you're refractory to a specific drug, do you keep doing, are you always refractory to that drug? Like, let's say, for example, he'd taken Revlimid 8 years ago. Could it be combined in a different combination and kind of work again?
Yeah, that's a great question. The short answer is it depends. In most other cancers, if you become refractory to a drug, it might not work. But some of the drugs that we use for myeloma work more like, can they reach a certain threshold that they can induce cell death? And in general, those drugs that, like the Revlimids and the Pomalyst, as well as the Velcates and the carfilzomib, the Kyprolis, sometimes they stop working with one particular combination, but they could add to the next combination. So a great example, for instance, is with selinexor. When we're facing someone who needs selinexor, even though the patient may have progressed before on something like carfilzomib, the Kyprolis, or the Velcade, we may still use it in combination because they put certain level of stress on the cell, even if upon themselves they were not able to put the cells off that line that would make them die off. You put them and then you add something like selinexor, and then you can see good responses. So I would not say categorically that if you have used a drug and the drug stopped working in the past in one way, that it might not work in a different way in the future.
Okay, great answer. And I'm gonna ask one last question. I'm so sorry that we can't get to all your questions. We have so many. I didn't even make a dent in the questions. And I want you both to answer this question. Deborah is asking, what are your thoughts on control versus curing this disease? Very broad. Dr. Fonseca, we'll start with you.
So I think that more and more, I don't think that has been a complete absolute because it depends on the patient population and it depends on the status of the person. Mm-hmm. But my goal is that we continue to aim for a cure, because cure is permanent control. So that's it. But it can only be achieved if it's done safely. When we have good treatments that are making that be possible, like what Dr. Langren is doing with the Manhattan study. So I definitely sit on the camp of more of the cure. Not only that for upfront, but I think for the first relapse, I'm going to say that the first relapse should be seen as a second opportunity, a second chance. Because historically we've gone from first relapse being, okay, we'll just try to keep things under control. But we have some results that are really spectacular with Candara, Chema, Pollux, some really good results, the CAR T cells, the bispecifics. I realize it's not always possible. I realize that there's patients where we kind of just try to hit that control mode. But I would say 90% of my efforts are more geared towards cure.
Okay, I love hearing that. Dr. Langren?
Yeah, I'm absolutely in that camp too. We are trying to use integration in our program with very sophisticated assays for profiling of disease. We're trying to implement all the single cell and whole genome sequencing. We are trying to do the immunopet. We are developing these blood-based approaches. We're developing new MOD tests. We're also using these combination therapies. Rafael mentioned the Manhattan trial we developed. The latest we are working on right now in this kind of direction is to use myeloma genomic defining events, where we have used the genomics to see that the fraction of people with smoldering myeloma and even a very small proportion of MGUS patients have genomic signatures that are virtually identical to what you see in myeloma. And people will, with a very high rate, like maybe 90-95%, develop myeloma in a 5-year window. So I think we're trying to see if we can design studies for people who have genomic defining events and use immunotherapies to try to wipe out the disease before it causes problems. So our intentions are really to seek a cure, but we also don't want to just throw every drug, because that comes with a lot of toxicity. So we do it in a controlled and very rational manner with these different types of analytical approaches.
Mm-hmm. Well, it's been such an amazing session. You two are fabulous. I'm very privileged to know you. We are incredibly lucky. And I want to reiterate your point, Dr. Fonseca, about seeing a myeloma specialist, because as you can hear, the difference between someone who's treating 25 different types of cancers versus somebody who's just seeing myeloma is really stunning. And your expertise, both of you, is just so deep and rich. We're just so lucky to have you in the myeloma research world. So just thank you so much for all you do, for taking time with us today. And I just
The
want to thank you.
privilege is ours, Jenny.
Absolutely. Thank you so much for having us, Jenny. You are the best.
Oh, I'm so grateful to both of you. Now, before we go today, I just want everybody out there to know that we are planning our first live roundtable on Saturday, October 16th in St. Louis, Missouri. We're going to have a very diverse and interesting lineup of speakers. We'll focus on immunotherapies, barriers, personalized medicine. And for those of you who are in the area who might want to travel there, we'll be in a very large room. There will be enough place for safety and hygiene and all that. And honestly, we just want to start seeing people again. And for those of you who can't attend because out of caution or other reasons, we'll just have a live webcast and we'll make the recordings available. We'll also have an announcement about a roundtable soon in New York City on November 13th. And just with that, I want to thank you, doctors, again, and our audience. And we just have so much, we learned so much from each of you, and having you together was a very big treat for me. So thank you again.
Thank you so much.
Okay.